Well, I think we'll get started, and if you have any friends out in the hallway, they don't want to miss out on our next speaker, so we'll get things underway. I am Pat Atwall. I'm the CEO of Inland RCM. We are a revenue cycle management company based in Spokane, Washington, and we've been around for quite a while, and we do the full scope of rev cycle services for medical billing, claim denial management, coding, cash posting, and the reason clients choose our company is how long we've been together. My team, some of us 20 plus years, they are true experts in what they do, and I love being out at these events and representing them. They're a hardworking team, and clients like the fact that they're working with people that have been doing this for a long time. As we all know, there is nothing simple about medical billing and making sure we're supporting our hospitals and getting them paid. And we are an all-American team. We are owned by Inland Imaging, who invest in us and support us, so we've been able to resist the idea of being acquired and having the work shipped overseas, and that makes a big difference to our clients. Our clients are rural hospitals, critical access hospitals, and rural health clinics. So if you have any questions about that, or if you have any interest, or you have friends who are, just let me know. I am here at the event. I'm also the VP of Programs in this wonderful organization. So with that, I would like to, before I do, I'm supposed to let you know that it's a reminder, if you require CPE credit, please sign in on the iPad at the back of the room. So with that, I'd like to introduce Zosia Stanley, Vice President and Associate General Counsel of WSHA, and she has a great session for all of us. Thank you.
Microphone works, and it totally works. Hi, everyone. Good afternoon. Thank you for having me. As mentioned, I'm Zosia Stanley. I'm with the Washington State Hospital Association. I have spoken, I think, with you all maybe in Spokane a couple years ago, so it's really nice to be back. You often hear from Andrew Boos, who's my colleague, and he is busy doing, we'll talk about, many, many revenue things with the legislature. So today you get me. So I have about an hour to talk with you. I welcome questions as we go through. It's more fun to have a conversation than to listen to me for an hour. I don't want to listen to myself for an hour, so questions are very welcome. I might not know the answer to all the questions because things keep changing at both the federal and the state level. I think you just had a presentation about the dynamic nature of all the things at this point, and I will continue that theme. So a couple caveats before we begin. I'm an attorney. I'm not your attorney, so no legal advice. I will give you information that is correct and updated as of like 2:33 on this date. Although I just did get an email with a new executive order, so all those things. The state legislature is in session right now. It's day 94, 11 days left. They are doing a ton of work, so that will also change. And finally, I'll say I am an attorney. I'm not a finance expert, so I will do a little bit of light finance, but if you have deep finance questions, I will give you to Andrew. And I will not talk about arbitrage or any of the other finance things that you all want to talk about some days. So there you go. Those are my caveats. I am an expert in health policy and Washington state politics, so I'm happy to talk about that. And now I'll figure out if my clicker works. Totally does. All right, as mentioned, I'm with WSHA. We are the Washington State Hospital Association, a trade association in Washington state. We're not a state agency, although some people think, given our name, we are. We're really happy to have universal membership. Every hospital in the state of Washington is a member. This is one of our most popular items that we have, a map of all the hospitals in Washington. So this includes public hospital districts, critical access hospitals, hospital systems, behavioral health hospitals, state, VA, et cetera. So if you work for a hospital, you want to raise your hand? If you work for a Washington State hospital, you're a member of WSHA. Thank you for being a member. We are always here for any questions, any resources, questions you have. We are happy to at least try to answer the question or find you somebody who can. Our mission is to support the mission of our members, and our vision is to be a trusted voice and indispensable resource to lead, challenge, and assist hospitals in the state. So obviously, we are very busy. All right, so today we'll talk a little about the healthcare landscape, specifically the kind of financial state of hospitals in Washington state. I know this chapter includes some Alaska or other non-Washington folks. I'll talk about Washington, but you can probably extrapolate a lot of these points for other hospitals in other states. Then talk about some federal updates and give you all the caveats again about the fact that this is very changeable. I appreciate folks in this organization let me change my slides many times because there are many updates. We'll talk about the state legislature and their work. They're a little bit more predictable, but still some uncertainty there. And then we'll end with a few practical considerations because we're going to talk a lot about uncertainty, so we'll leave you with a couple thoughts that are a little bit more certain. And as I mentioned, please ask any questions as they occur to you. We'll go forward. So hospital finances, I think if you work in healthcare, you are aware that finances are pretty fragile across most of healthcare at this point. It's something that you all probably deal with every day, I deal with every day. But it's interesting to talk to the public, the media, legislators, because they say, well, but you're busy, right? Most hospitals are at 95, 110% capacity, right? You obviously have enough people coming in. So why is the revenue hard? You're big systems, you have a significant revenue, why are your margins thin? And so we do a lot of conversations where we talk about the fact that COVID was such a blow to most of our economy, especially hospitals. And so although hospitals are starting to come out of that COVID hit, they don't have the reserves they used to have. And so we're all in a position where we can't take another blow like that. If the feds cut Medicaid rates, if the state decides to put some really big taxes on hospitals, there are concerns about the viability of our system. So we often start by talking about the fact that 7 out of 10 hospital patients are government pay, Medicare and Medicaid, meaning that's less than the cost of healthcare is the payment rate. All of your heads are nodding. You are my people. When we talk to the media, there's a lot of like, well, but why would that be? Like, how could that work if you were paid less than the cost of healthcare? And so we do the conversations about cost shift and other things that occur in our industry. But this is, I think, an important place of kind of level set, right? And then we do a quarterly survey of all the hospitals in Washington State on finances. And so this is results of our financial surveys. And as you can see, we continue to see some really significant shortfalls. In 2024, you'll see that the shortfall is less than it could have been, and that's in part because of the safety net assessment program that the legislature passed 2 years ago. That funds have really helped. It raises the Medicaid rate essentially. That's also called a directed payment program at the federal level, and that is in some jeopardy. It's unclear what the feds will do with the DPP programs. Some states have been approved, some states have not. We have not yet, and so that's, I think, an open question about whether that funding will continue to be able to buffer those revenue realities. The other thing, of course, you're all aware of, right? The growth in healthcare, growth everywhere, the cost of everything has kind of gone up, but especially in healthcare, right? Workforce, operations, all the other things. So that's a lot of the conversation we have with legislators is you got to take the whole picture of what it means to be a hospital or healthcare provider in this day and age. So this is another way of looking at our financial information. A couple things here, right? For the first time pre-COVID, we see a positive net income in our hospitals, which is very good. However, we went from margins of only -1 instead of -5. So that's still not a really healthy place to be. The improvements are mostly because of the directed payment program I mentioned, the SNAP program, and then also because the stock market has been okay. Investments have been doing well. This is, of course, 2024 numbers, so this doesn't include some of the more recent volatility. Also, it's a bit of a mixed bag. About 80% of hospitals are still in a kind of losing money position. A lot of our small hospitals and big hospitals. Some of our mid-sized rurals are doing okay. Again, still not healthy margins, but doing okay. Another way that we're looking at this, right, is to think about, healthy margins. This is just another way of looking at the data, and I think it still shows this picture of some hospitals are doing okay, have getting to a healthier margin, but in revenue, but not there yet. So we will continue to try to educate people around what it means to be in healthcare these days and be a hospital and health system. And days cash on hand still in a place where it's getting better, but still not great and healthy. And when we talk about hospital finances, especially with the legislature, and I think as you all are talking to your community members, we really try to tie this back to why do you care? I mean, obviously people want to have a hospital, they want to have health care, they want to have access, but we tie it back to what does it mean if your hospital doesn't have great finances or isn't really financially healthy? What choices do they have to make? And that usually means they have to think about what services are really challenging to provide, which ones do we need to either cut back or be thinking about whether we can sustain. We talk a lot about OB and maternity services, right? Those are really expensive services to provide and sustain, and obviously super important to our community. So we try to make sure that we are talking about that patient perspective and the patient impact. Okay, so I should have said, this is not an uplifting conversation necessarily, so I apologize in advance. I will try to get so uplifting where I can, but finances are better than they were in the depth of COVID. They're not great. Now we get the federal updates. And again, I just got a text that something else has changed, so I will give you what I know, and we can have a conversation. Please do ask questions as they occur to you. I may not always know the answer, but we can at least have a conversation about it. So context of uncertainty, my favorite, the known knowns, the known unknowns, and the unknown unknowns. I think we have a little bit of all those things. I was thinking about this presentation and thinking for the state level, right, we have some pretty clear deadlines, structure, next steps. There are things that are different this year because our budget deficit in Washington State is bigger than it's been in many years, but we can at least predict what probably will happen next, or at least what the steps will be at the federal level. Cannot do that, so I will just give you the updates that we have, and we can think about what we may see next. So we'll talk about some of the federal agency decisions, we'll talk about some of the executive orders, and then some of the congressional decisions. And again, these are updates. We could spend a lot of time talking about all the things that have happened since the new administration came in, but we'll focus on the here and now. So we have Health and Human Services. So HHS includes CDC, CMS, FDA, Indian Health, National Institutes of Health, kind of all the healthcare entities are for the most part under HHS. Robert F. Kennedy Jr. is the new HHS secretary. He has lots of opinions about lots of things. He is a different character than we've seen in that role in the past. So you may fill in the blanks about the different things that he has opinions about. And then Dr. Oz, who was a media personality for a long time, is the newly appointed CMS administrator. I will say Oz was very well prepared for his confirmation hearing, pretty nuanced about CMS and the role of that agency, so I think there's some positivity, and he seems to be willing to dig in and be an expert in healthcare. So that's, I think, a positive for that administration. Interestingly, there's now a new administration for Healthy America. I don't know what they do, to be really honest. I don't know that anybody does. I did read their website. I can't tell you exactly what they do, but they seem to be interested in improving coordination of health resources and operational efficiency. So the buzzwords of they're going to do some things and it's unclear what they will be doing. We do know that there's a planned reduction in both the capacity of HHS and the staffing. Most federal governmental entities have had reduction in force, RFs, there we go. So for HHS, we've seen 10,000 positions eliminated. We anticipate there will be more. Interestingly, there are 10 HHS regions, and there's been a consolidation, so there will currently, moving forward, be 5 regional offices: Denver, Philly, Kansas City, Dallas, and Atlanta. Apparently, if you live on the East Coast, Denver is very far west, so that's as far west as you need to go for a region. The rest of us, just out in the ocean somewhere. So I think that'll be interesting to see. I mean, I don't know how effective I don't know how impactful it will be to not have an HHS office locally. We've had one for such a long time. I don't know what it'll mean to have that administration more removed from our local folks. So something to watch. The other thing that's interesting is HHS has been really focused on that theme of fighting fraud, waste, and abuse, which I think everyone can agree that we don't want fraud, waste, and abuse in our government. We spend enough money at the federal level that we don't want to do that wastefully. But the challenges are, in some ways, some of the things that there's a disagreement about what's fraud, waste, and abuse. So things like the vaccine programs are being looked at as waste or abuse, or the Medicaid expansion, which has been so impactful for us all. So we will see what happens next. I think at this point, there'll be a lot of conversations about why are programs necessary? And we have things like we're seeing measles outbreaks for the first time in a long time in Washington State and Texas and other places. And so that, I think, is an example of the role of government and public health that we need to continue to talk about. And the reason that we have good health care in the US is because we've invested over time. So next, we move to tariffs, everybody's favorite. I've given you this yes, no, maybe because last week, beginning of the week, yes, tariffs. Middle of the week, no tariffs, except maybe China. We were going to tariff, I think, an island of penguins. We decided not to do that for a while. We might do it again. So right now, pharmaceuticals and a lot of the kind of semiconductor copper are not subject to tariffs, but we've heard we're going to put pharmaceuticals under tariff schemes. No, we're not. Yes, we are. I don't know what will happen next, but I think it's something to watch for, because we saw during COVID that, especially with some of our supply chains in healthcare, it is just in time, it's done in one spot, or it's hard to get to and hard to ship. So I remember during the beginning of COVID, the question of, where do you buy masks, right? We had local companies that I will make masks for you, but it didn't really work. The scale didn't really work. We had local companies that said, we'll make disinfectant for you, but it didn't, again, the scale was hard to get to. So I think we'll see companies that are doing manufacturing of medical supplies begin to make different decisions because of this worry about tariffs. According to the Healthcare Industry Distributors Association, healthcare distributors have a really low profit margin. They're about 3.2%, which, per our prior conversation about margins, not as bad as it could be. But still, it's a tough margin to deal with. So I know that there's advocacy at the federal level around, should we be moving things locally? Can we have exemptions for some of our healthcare-related items? And I don't know what will happen, but I think it's an interesting one to watch, because we already have such huge, I get it, right? A lot of concerns about the cost of healthcare in Washington State, in the US, and so what are the levers we're pulling to make it less or more expensive? There we go. All right, so we've done HHS, tariffs, just a potpourri of issues, so other administrative areas and ideas. So the Biden administration proposed a rule that would have required specific nurse staffing or staffing ratios in nursing homes and skilled nursing facilities, which sounds good, and I think we have a lot of concerns about nursing homes post-COVID. The challenge is that it's really hard to find that workforce. That's very expensive, and if you have a nursing home that says, I could take a Medicaid patient at a pretty crummy rate, or I could not if I can't afford it, under that rule, we could have seen more nursing homes say, I can't accept your patient from the hospital because I can't afford to take on the staff necessary to sustain that service. And so we are pleased that on, I think was April 7th, a federal judge struck down that rule, and we don't think the administration will appeal, so that's good. The challenge is that political math is a funny math problem, and so I think it was the House or the Senate was assuming that they could repeal that law themselves and they could bank $22 billion of savings. If the court overturned that law, that means that the Congress can't take credit for those savings, which means that they're going to have to find $22 billion somewhere else in cuts. So the political math didn't work out. Good result on policy, tough result on budget. We've also seen some proposals around Medicare Advantage rules. Dr. Oz in his confirmation seemed to be a pretty big fan of Medicare Advantage. And he seems to be a little bit more moderate when it comes to prior authorization questions, which I know have been concerns with MA plans. But we have seen new rules, so a rate increase, some of the loopholes have been closed, and some of the kind of prior auth issues have been marginally addressed. I would say that they left out some things that could have been addressed, like the role of AI, and then some local issues when it comes to kind of MA plans advertising hospitals being in network when the hospital is not actually in network, which obviously is a challenge for patients. So I think there's more to come on the MA side. And then I have a positive, just a moment. The suspense is killing you. Deregulation. So I think in healthcare we have all experienced that we are a deeply regulated industry at the state and federal level. And so the feds have indicated a willingness to think about deregulation. And the OMB, I think late last week, put out a request for information to say, hey, are there regulations that seem unnecessary in healthcare or over the top or duplicative? Tell us about those and we might consider either fixing them or repealing them. So interesting ideas. So there's a new regulations.gov website, and you can go on and make suggestions about regulations that you think are not necessary or are overly burdensome or duplicative or just silly, which is also a standard sometimes we use for analyzing some of these laws. This also aligns with Trump's EO from early July, where he said, for every one new regulation or rule or piece of guidance, we're going to repeal 10, which is an interesting idea. We'll see how that goes, but I do think there's an opportunity to have potentially maybe a more rational regulatory structure. So we shall see how that goes. Turbulence ahead. Again, with my theme of uncertainty, I should have gotten a wave background here. So we know that the federal government, Congress, would like to cut, some pretty significant spending from the federal government. The House has said that they want to cut $880 billion from the Committee with Medicaid Jurisdiction. That's real money, 880 billion. I don't think it's going to be that much in the end, but that's their target. That's what they're talking about. And so that means that probably a lot of cuts that will be impactful will be considered. So things like ending Medicaid as an entitlement or transitioning to a per capita cap on how much funds states get. Those seem to have kind of faded as ideas from Medicaid changes, but the work requirements could and probably will become something that will move forward as the crystal balls are broken after COVID. But the crystal ball we have seems to say that workforce or work requirements are probably going to be put into place. That's obviously a paperwork concern for people, and it really, I think, can mean people cycle on and off of Medicaid as they get their work requirement paperwork in and out of shape. So that is a concern about patients' access to health care. It can really be a continuity of care issue. We also have seen proposals around changing the FMAP percentages. So FMAP is the Federal Medical Assistance Percentage, and for traditional Medicaid, it's 50-50, 50% federal, 50% state. For expansion, it's 90-10. If the feds give the states less money, the state has to either provide fewer services, pay less of a rate, or find the money elsewhere. And to give you an idea, just a little preview for the state side, there's no money for that. The state's looking at a $12 to $16 billion hole over the next 4 years. So that's not looking great to find additional money if the feds decide to give the states less money. We're also looking at some ideas that we're not sure about directed payment programs, also known as SNAP in Washington State. SNAP, not the food stamps at the federal level, but the Safety Net Assessment Program. And then we may see a repeal of rules and processes that help people stay on Medicaid. So things like allowing people to come out of prison or jail to enroll back in Medicaid right away, or maternity services, coverage for pregnant women. So all those things are uncertain at this point. I think that though that we will continue to see, a substantial drive in both the House and the Senate to push for cuts. And just a reminder, in Washington State, our Medicaid program is called Apple Health. We find sometimes that people will say, well, yeah, you should cut Medicaid. Like Medicaid, we should be really more thoughtful. There's probably waste, fraud, and abuse. Someone should be thinking about that. And then it turns out that they actually get Apple Health. They're Apple Health recipients. They just may not understand that Apple Health is Medicaid. And I looked it up just because it's always interesting. Almost every state has a different brand for their Medicaid program. In Alaska, I think it's Denali Health. California's Medi-Cal. And I really enjoyed Oklahoma is Sooner Care, which I just thought was delightful. So just a reminder, as you're talking about Medicaid, to tie it back to whatever your state's Medicaid program is called, because it helps people understand the actual impact for them and for their family members. And I just enjoy this chart because it's like a 300 level of like the I'm Just a Bill from Schoolhouse Rock. So this is the budget reconciliation process. So we've talked a lot about the possible potential cuts, 880 billion, et cetera, but we're pretty early in the process. We're way back kind of in step 1.5. We have to have budget resolutions adopted. They have to be reviewed by subcommittees. We have to have a reconciliation process between the two, the House and the Senate, because they never agree, because it's the government never agree with each other. And then we get to reconciliation and passing a bill. So we're still pretty early in the process. We're thinking that when we get to step 2, that's where we're going to see some pretty hard policy decisions and policy discussions and more concrete proposals. The other thing we're thinking about is that reconciliation is probably a July endeavor, although who knows, it's already late April, so probably July, could be after August recess. And my friend who does a lot of our federal work has said, we're definitely in a marathon, unclear if it's a regular marathon, an ultra marathon, or an Ironman. So we're starting a marathon in this issue, and we'll see how far we have to run to get to the end. And then this executive order piece I think is interesting. We have obviously seen a ton of executive orders coming out of the White House, and almost every administration does executive orders. We have seen, though, more executive orders, I think, from this administration early on in kind of the volume. We've also seen a willingness of Congress to allow executive orders and the president to expand his powers that would often be congressional powers and now are more presidential. And EOs can have the effect of program closures and costs. We have seen, for instance, the DEI EO has resulted in a lot of scrutiny about education and healthcare and DEI's programs in a number of different levels and areas. And I think a lot of people being cautious about using that language, what words we use. For the protecting children from mutilation or gender affirming care, we have seen new investigations naming both hospitals and educational facilities. We just saw yesterday a new investigation was open for a children's hospital. I don't know which one it was. But there's also a whistleblower process now for healthcare providers or patients or family members to flag if they think that their a healthcare entity is not doing care that they think is appropriate. So I think there will continue to be that kind of caution when it comes to these protected health services that some people agree with and some people don't. And that's unfortunate when we get to healthcare, where we want to make sure we're giving patients the care that they need at the right time and place. There have been many lawsuits filed against various decisions the federal government has made. I will just touch on one of them. The most recent one that we have seen, well, I don't know actually if most recent. It was recent when I drafted these slides a couple days ago. So we saw the federal government say we're going to claw back $11 billion in public health funds from states across the U.S. In Washington state, that's about $160 million hit. That's real money for the state. That's vaccination programs. That's communicable disease mitigation efforts. That's a lot of money for our Department of Health and other entities. So Washington State's AG, we have a new AG, Nick Brown, who has been pretty active suing the Trump administration. He joined a number of other states to seek a temporary restraining order, which he did get, which is good. So we'll see what happens next, but we are continuing to watch that because, again, without that federal funding, either the program doesn't exist, it is less impactful, or the state has to find the dollars. Which the theme is the money is not easy to come across at this point. Okay, so there is your update on what the federal government is up to. Lots more. The email I just got was about an EO around pharmaceutical costs for Medicaid and Medicare. It said something about purchasing drugs at the same rate that hospitals do. I don't know what that means. I don't know if that's 340B or if that's something else, but just know that EO was just released at about 1:30 today. So with that, questions about the federal government? All right, well, you may hold them, but feel free to ask them. I don't always know the answer, but we do, if you're a WSHA member, we do every other week, I think they're Wednesday or Thursday afternoon webinars where we give an update about what's happening. So if you're a WSHA member, you're welcome to join that conversation, and we can give you the latest and greatest, and hopefully we'll move along our reconciliation chart, and we can show you where we are each week. All right, well, we will move to the state legislature then. They are, as I mentioned, more predictable in process, but still some delightful wildcard opportunities. So in Washington state, so every state has a different cadence that their legislature meets. In Washington state, it is a biennial process. They always start the second Monday of January. In odd years, which is 2025, it is a long session, 105 days. It's the first year of the biennium. The legislature passes policy bills and then has to pass a balanced budget. If they don't pass a budget that gets passed by the House and the Senate signed by the governor by June 30th, the state shuts down because there's no money. July 1st is the fiscal year. The second year of the biennium, the even year, is a year that they can do some tweaks to the budget. They do some policy bills. It's 60 days of session. And so we are in this, we're getting to the end. We're day 94, 11 days to go. They have about 300 hours left, a little bit less. They're supposed to adjourn on April 27th, which is a Sunday. They work weekends. I put an asterisk here because I don't know that they're going to, I don't know if they're going to make it. They might, you never know. But they've been really wrestling with that $12 to $16 billion budget shortfall and how to fill it with either new revenue or cuts. We've seen proposals of an all cuts budget. We've seen an all revenue budget. We haven't done this type of exercise of needing to fill a budget hole since probably 2017 maybe. We did, I think, 3 special sessions at that point. So if the legislature can't agree on a budget, the governor can call them back into special session, which nobody I think wants to do. Everyone's very tired, but it could happen. The other thing to be aware of is today is a big cutoff day. It's opposite House cutoff day. So every bill has to start in the House or the Senate. You go to policy committee, you get exec out of the policy committee, you go to appropriations or a fiscal committee, you go to rules, you get pulled to the floor of the House or the Senate and voted out of your chamber of origin, then you cross over and do the same thing in the other House. And today's the day that policy bills and most bills have to be voted off the floor of the opposite chamber. So you may have seen, if you've been watching the news, the House I think they went to 11:30 last night, but they went to 3 a.m. the night before, 2 a.m. the night before that. They have a ton of bills they're trying to get through, and so what they have to do today is by 5 o'clock they have to name their 5 o'clock bill. They can still do other bills that they've already have open before, until They don't have to do the 5 o'clock bill at 5 o'clock, but that's the last bill that they can hear before they have to be done with new bills or new bills off the floor of the House or the Senate. We have seen, I think, some real tension in the House especially. You may have seen the parental rights. This is not healthcare, but I think it's interesting because it gives you context. Parental rights bill was passed last year. It was one of the initiative packages. The legislature decided to pass a couple of those initiative bills. Some of them went to the people. The parental rights bill was passed. There's proposals to change it, and I think it's become a sticking point between the R's and the D's about what kind of policy we want as a state, and the R's being a minority, right? The Democrats control the House, the Senate, and the governor's office. So the R's have, they don't have the power of the numbers, so they have the power of the process. The D's have done a little bit of work to try to kind of limit the process games that can be played, but we have been seeing in the last couple days that on the House floor a lot of voice votes, which means you have to spend lots more time in every bill to voice vote every amendment in every bill. So it is unclear if all the bills that people want to be passed will be passed. We have a couple bills we'd like to see passed that are waiting to be voted out of the House, and it's unclear if that will happen. So TBD. As I mentioned, 300 hours-ish, probably at this point 250 hours for them to figure out what they're going to do with budget and policy bills. So I have some older slides and some newer slides. This is an older slide, but I think it's helpful to see kind of where we started. So we knew going into session that we did not have enough money coming in. We were spending more money as a state than we had money coming in, or revenue, or rainy day fund. And so we knew when Governor Inslee was leaving office, he'd been our governor for 12 years. He had some budget proposals. Governor Ferguson coming in didn't make initially his budget proposals. He kind of waited to see what the House and Senate would do. Both the House and Senate made proposals. These, I think, are interesting to kind of give you an idea about where people's minds are in thinking about new tax policy in the state. We don't have an income tax, and our Constitution won't allow us to have an income tax, so we do other things instead. So proposals have included a B&O tax. The original proposal was a 1% increase in taxable revenue above $250. There was also a wealth tax, which is a tax on intangibles. If you are a very wealthy person and you have lots of assets, that could be a tax on that. You've probably seen that Governor Ferguson was very skeptical about that, the constitutionality of that proposal. So he said he didn't think that the House or Senate should be relying on that money coming in, because it could not if the court overturned it. Also a lift on the property tax lid for education, and then a payroll tax based on the Seattle, I've lost it, not spring forward. I'm sure there's a very witty name for the Seattle payroll tax, but it's basically, instead of having, you can't tax people's income, but you can tax their payroll, which means that if you're an employer of a certain revenue size, and you have employees making more than the Social Security threshold, you'd have to withhold payroll tax for them. So those are the proposals. I think that, again, the wealth tax and the payroll tax are the ones that seem like the most least likely, most concerning, most people being concerned about. Just really briefly, the House B&O tax, this is kind of what their structure was. I won't linger here because we have a new B&O tax proposal that landed yesterday. The payroll tax proposal, we have not seen this be proposed as of yesterday, so we don't think this is going to be a tax proposal going forward, but we'll see. And this is my new slide, and these are the titles of the bills that were introduced. They're all getting a hearing in about an hour and a half. So they were dropped yesterday on tax day, which is delightful, tax day for tax bills, and they have a hearing today, and they're going to be exec, I think, on Friday, meaning they're going to be voted out of their committee. So two to flag especially that will have an impact on healthcare. Most of these will have an impact on lots of us, but healthcare directly. 2081 and its companion bills 5815. Modifying the B&O tax surcharge rates and advanced computer surcharge cap, blah, 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 blah. What it means is that for hospitals and healthcare, there is a 0.5% B&O tax surcharge above the $250 million of taxable Washington revenue. For hospitals, Medicare and Medicaid payments do not get taxed, so that would be exempt. For anything below the 250, it would continue with the current B&O rate, but everything above 250 gets that additional surcharge. This also applies to doctor professional fees. So we are at this point thinking that this will be potentially a $60 million a year for hospitals, somewhere around 17 or 18 million a year for the professional fees. So this is potentially really substantial impact. And then the other one I wanted to flag is the one at the very bottom of this list. So this is an interesting one, an excise tax. It's an excise tax on a number of things that are services, so tech consulting, IT tech training, security services, temporary staff services, custom software. So that could mean traveling nurses, temporary staff that hospitals or healthcare providers hire. EHR could be subject to this tax because it's a customizable software. Security services, something around background checks. Again, we just got this bill late yesterday, so it's still a little bit unclear to me. It's at least $100 million a year hit on hospitals and healthcare. When this bill is heard later today, I think there will be many, many people saying, I am worried about the impact on me and my business and my small business or my ability to continue to operate. And I think legislators are going to be listening, but I also think that they are so tired, and they're also at a place where they got to fill a $16 billion hole, and you can only do that with so many levers. And even this package is only about $12 billion. So we're probably going to see another pulse or a budget bill that will include the cuts. So this is the revenue, and we're waiting to see what the cuts are going to be. The other couple I'll flag in here, there's education funding, because again, the state has a paramount duty under the McCleary lawsuit to fully fund basic education. The state's been doing that for many years, trying to fill the education hole. They've been doing a decent job, but I think they still have some concerns about special education and a couple other types of education they have to figure out how to fund. And then the other one, there's an increase in capital gains and the estate tax. So I think it'll be interesting to see what policy levers, tax levers, the legislature decides to move forward with. So, as I mentioned, we will see what happens next. If anybody would like to watch this hearing, if you are a tax nerd and would like to see what people think about these revenue packages, Washington State has something called TVW, which is our version of C-SPAN. It is delightful. It's live. You can watch it recorded. I really love TVW because it allows you to see what the legislature is doing and what the hearings are, and it is fascinating if you are a policy wonk or any other type of wonk in the legislative arena, because it is a fascinating way to watch things go by. All right, any questions about what the state's up to? All right. So we mentioned the revenue sources and the new proposals and the anxiety I think lots of people are thinking about when it comes to what's going to happen next. In addition to that, as I mentioned, we will probably see cuts or other sources of revenue, other policy bills that have a revenue aspect. The one that we're concerned about is the PEB-SEB bill. So the state employee, public employee benefit plans are a payer, right? So for those people who qualify for those insurance packages. And the proposal in this bill would be a cap. It would be a mandate to contract. It says if you are a PEB and SEB carrier and you go to a hospital and you offer a contract, and it is at or below, I think they started at 180% of Medicare, you have to accept that contract. So that's a pretty significant precedent in our state law to say if you have a mandate to contract with a carrier. The other thing it does is a cap that ratchets down over time, and it's one that we are quite concerned about. We think that this would be a significant financial hit to hospitals, and we've talked about how concerning the financial realities already are. So this is one that we are opposed to. We don't think it's the right approach for the state, but this is one that we, knock on wood, but 11 days left, it's probably going to move. It's just a question about what are the caps, what levers are they going to pull to decide what savings they want to draw out of this program. Interesting, this is also a policy decision by the sponsors. They view this bill as saying, we think that we spend too much in hospital health care, and appreciate, as somebody who represents hospitals, healthcare is wildly expensive. Nobody disagrees with that. The challenge is that you can't just push down on one part of the system and hope that it, makes everything less expensive, unexpensive, cheaper. The theory that they're operating under is if we pay hospitals less, then we can use that money and pay for behavioral health and primary care services and other things we want to increase and get people to get preventative care and get behavioral health care. The challenge is that a lot of times those services are attached to hospitals or part of a healthcare system, or it's not like $1 that you can just transfer between care providers. So I think it'll be interesting to see where this concept goes, and then what additional steps people will take to kind of continue to work on that cost of healthcare question, because it is one that's really challenging, and it's hard to do at a state level to really push down on the levers that make healthcare expensive. Acute care is expensive, pharmaceuticals are expensive, we don't have enough primary care providers or behavioral health providers, But it's not, it's one of those like simple problem, simple solution, really complex problem you can't use a simple solution for, so we'll see what happens next on this one. The other things that were considered cuts or revenue-wise, there was an idea to claw back the DPP, the Designated Payment Program, or the SNAP program. We were really concerned about that because that's a program where the state and hospitals put up money to draw down federal dollars, and that federal dollars are used for state and Medicaid payments. We're hoping that that doesn't come back. We thought that was not the right way to go. There's also ideas about cutting Medicaid professional fees. The challenge with that is especially, I mean, you think about like pre-ACA, how tough it was for Medicaid patients to find providers who could care for them. And so we think that, reducing the professional fees for a service that's already a challenge to pay for is, I think, although you could save money, you probably wouldn't get people any more access to health care. The other couple that have been thought about is facility fees. We often see those as off-campus facility fees for specialty clinics associated with hospitals. The challenge there is, yes, facility fees add additional expense, but it's often the way that the hospital can provide specialty services to Medicaid patients. So a lot of conversation about what is the role of facility fees, why do we have them, a lot of education there. So we haven't seen that proposal come back, but it could. And then 340B, there's an idea for the state to kind of extract the discounts and use that money for the state instead of it going back to the provider. So we'll see. It's unclear to me what will happen, but I'm hoping that, I think at this point, these four in the list, the bottom of this list, probably are not going to be included, but again, nobody's crystal ball is great, so we'll see what happens. That was my theme, we'll see what happens. Okay, so this is just a way, this was our we have a whole new table we came up with at 2:15 today, so it's not updated on the slide, but this is our prior table about what the impact could be of some of these proposed cuts. So this is, again, the PEB/SEB bill, the B&O increase, which is a little bit different than what the current bill is, and then the payroll tax, which is off the table. But just the PEB/SEB bill, right, we have a $58 million hit, moving up to $341 million, which is substantial. So we're doing a lot of discussions with legislators in the next 250 hours that we have about what policy decisions are they making with their tax proposals and what the impacts will be for them and for our hospitals and communities. So we will know, well, I guess we'll know, they'll exec it on Friday. They would have to vote on it in the next couple of days, so we'll see what happens. I also think that it'll be interesting to see what the governor does. I've heard that the governor's office has agreed on these revenue package bills, but it's unclear if that agreement was yes to the concept, TBD on the language, since the language, I think they drafted it in like 24 hours. Ferguson has shown that he is, although he's a Democrat, he doesn't seem to be willing to agree with all the Democratic leadership in the House and the Senate, so it'll be interesting to see if he agrees and goes along with these packages if the bills change as they go through the process. All right, a couple other cuts to talk about. These are cuts that have been proposed. The House and Senate both proposed budgets, and so that's where these are coming from. So they could come back in the budget bill. A couple things. There have been a variety of rate increases, especially for long-term care. As I mentioned, hospitals are 95 to 110% capacity, meaning that they have fewer beds than there's demand. Washington State is probably one of the most underbedded or lowest bed numbers of any state in the U.S. So we don't have a lot of excess beds. At any given time, somewhere around 10% of our hospital beds are used by a patient who doesn't need to be in a hospital, but they're stuck for some reason. Either they have a more complex need than long-term care can care for, or they're waiting for a prior authorization, or they have a behavioral health need, or the SNFs don't have enough capacity to take them in. And so we have, over time, the last probably 5 years, we at the association have really advocated for increased spending, especially for the Medicaid population, to help get those patients out of hospitals. Hospitals are great at acute care. We are excellent. We're not great at long-term care. We're not a community living space. People don't want or need to live in a hospital. So we've done a ton of advocacy to say if you can increase a rate for behavioral health or dementia or assisted living facilities, we can get people out into the communities where they should be. And unfortunately, I think the proposals so far have been to really go backwards when it comes to that increase in access to long-term care. We've also seen a number of proposals that would close the capacity or reduce the rates for developmental disability clients, so IDD patients. We've seen proposals to close the Rainier School and the Yakima School, and those are some of the very few places where really complex DD patients, especially younger adults, can live. If we don't have that kind of capacity, then those patients end up in hospitals. And for the most part, hospitals don't get paid to care for those patients. So we have a bed for a person who doesn't need or want to be there. It's not a good place to be, and there's no revenue coming in for that patient. So a lot of these proposals are things that will move us backwards from where we have been the last couple of years. There is a proposal for a 1% cut to MCOs. That means that those MCOs will have to figure out where to get that either revenue or do cuts or have less administrative process, which, the administrative process is not always great, but you do need somebody to do prior auth and utilization management and all the other things that the MCOs do. Adult and child dental was added to the Medicaid program a few years ago, and that has been a really important additional service for those patients. And we are seeing rate cuts proposals, so people would still have that coverage, but the rates would be such that probably not a lot of dentists would want to take that rate or that payment. We are also seeing proposals around moving the age-blind and disabled population in Medicaid from MCO to fee-for-service, which seems like, okay, we're just moving them around the Medicaid world. The challenge is that the reason that is proposed is because it is harder to navigate the fee-for-service side, which means that there would be savings because people would get less care. The other thing, as I mentioned, the long-term care providers, and then we have seen the service cuts, as I mentioned, with the Rainier School and the Yakima School. So the last time we had a really bad budget season atmosphere time in Washington State, we saw massive cuts to Medicaid, to long-term care, to the DD population, and we're really hoping not to go back and live in that world again because it's taken us a long time to try to get out of there. I am concerned that there will be some cuts to these social services, and we're going to get back into that world where we're going to see patients not getting the right care because nobody can afford to take the rate that's being offered. All right. So we'll now move to some policy bills. We spent a ton of the beginning of session on policy bills. I didn't actually count yet this year, but there's usually, there's hundreds of policy bills that get introduced. The House bills start with a 1, the Senate bills start with a 5, and they can go up into multiple numbers. I think at this point we are at, for the House, 2,085, so that gives you an idea about the number of bills in the House. Senate, very similar. So just a couple bills that may be of interest. There are lots of bills that when we, at the association, we do a summary of what the legislature did at the end of each session, so we'll send that out to everybody if you're interested. A couple things, so the workplace violence bill, there's a workplace violence prevention planning requirement that applies to hospitals, home health, ENTs, evaluation and treatment, behavioral health, and ASFs. And it's an existing law, but this bill would require investigations of every workplace violence incident and annual report updates. So just a note, if you are a hospital or one of those entities, you'll have new obligations coming up. This bill is moving. It hasn't passed the Senate yet, no, it did pass the Senate. It hasn't been signed by the Speaker, so probably will be moving. There's a pre-pack medication bill that we are big fans of. We see situations where patients will start an inhaler or an ointment or something in an ED, and then they can't, under state law, they can't take that medication with them from the ED, so we end up throwing away that inhaler or that whatever it is, some kind of, if it's pills, we can divide them up and do pre-packs, but you can't divide an inhaler into subparts. So this bill would allow us to send that inhaler or that medication home with that person. No payment involved, but we're hoping this bill will move forward. It's a very classic, good little bill addressing an actual problem and then gets caught in either political process or people concerned about the bill doing things it doesn't do. So I'm hoping this one will move. I think it might. I'm hopeful, but we'll see. They have 2 hours to figure out which bills are going to move. The next one is the Healthcare Entity Registration Bill. There's a national organization called NASHB, which is the National Association of State Health Policy. And they're a really proactive, progressive organization. They do proposals around the cost of healthcare and healthcare consolidation. They have proposals around corporate practice in medicine. So this is one of their bills. There's a whole slew of them that were introduced this year. Healthcare Entity Registry Bill, I think it comes from a good place of saying, do we actually know who is participating in healthcare in Washington State? Do we know which private equity entities exist that are potentially purchasing healthcare providers? Do we understand the breadth and depth of a Providence or United Health Group or some of those big systems? The challenges that the bill has introduced would have required such data reporting that it was almost impossible to do at a level of financial granularity, and then would have required the Department of Health to develop a real-time, publicly available interface. And I think the Department of Health said, yeah, except that would cost us, a lot of, like, real money, more than just $1 million. And so the bill right now has been skinnied down, and it says, it directs the Department of Health with stakeholders to come up with, what's the language they used, to develop a plan and provide recommendations on how to create a complete and interactive registry of the healthcare landscape in Washington State. So that report, I think, is due in 2 years, so I think that'll be really interesting to see what the Department of Health and others kind of propose as a way to keep transparency on who is providing healthcare in Washington State. The next one is another that comes from the NASHB organization. It's the Healthcare Transaction Oversight Law, the Keep Our Care Act. This is the bill that I'm the lead on. This is a bill we've seen for 7 years. It's not moving forward this year, but its proposal is essentially to allow a state agency, the AG or the Department of Health, to have the power to approve, condition, or deny healthcare transactions, so acquisitions, contracting affiliations, mergers. And it's an interesting approach. The theory is if the state has more control, then they can keep down healthcare costs. I'm not sure that that works. I'm not sure that there's, oftentimes we see transactions happening because a small provider will say, I cannot make it anymore. I need a partner. I need somebody else to help me with the admin, the workforce, something. And so we have been opposed to many versions of this bill because we don't think that it's actually going to preserve healthcare in Washington State. That one will definitely be coming back. Maybe year number 8 is the magic year. 5041, this one I raised not because it's a healthcare bill, but because I think it will have an impact on all of us, potentially as employers or even workers. This is a bill that requires, I skipped ahead. 5041, there we go. So would force employers to pay striking workers for up to 4 weeks of unemployment. It started at 12 weeks, and the thought at that point was, if you have a Boeing strike or a big employer strike, you could potentially drain the unemployment system in a pretty short time. Hopefully that one will be 4 weeks, maybe the answer. It's unclear what the fiscal impact will be on the unemployment entity in Washington State. They already had a really hard time during COVID, so unclear. And I realized I skipped over meal and rest breaks. Meal and rest breaks is a bill that was agreed on by the unions and the hospitals. It clarifies hospital staff meal and rest breaks and waivers there too. So if you're a hospital person, just be aware that this law will come into effect. I think it's going to be helpful, but I think meal and rest breaks are an area of continuing kind of grayness. Let's see, the Uniform Antitrust Pre-Merger Notification Act. I know it sounds really interesting. I think it is. But it's if you are doing a transaction and you have to give the feds information about your transaction under Hart-Scott-Rodino, you give the same information to the state. Relatively simple, but will require some changes. If you're a hospital, be aware that there is a bill that I think is passed that will make more standard your records retention requirement. So right now depends on kind of the last time somebody got care. It's hard to figure out. There's lots of paper records. People are really concerned about destroying any records. The bill would require a 26-year record retention, just flat straight across for anybody at any age. So I think that will be helpful. It applies to any kind of records, paper, electronic, et cetera. And then last but not least, codifying EMTALA. We didn't talk about it as much at the federal level, but there continue to be concerns from advocates in Washington State about protected health services. So abortion, reproductive care, gender affirming care. Specifically for abortion care, EMTALA, the Biden administration interpreted EMTALA to say that miscarriage management is part of emergency care, and so if somebody comes to an ED and is experiencing a miscarriage, that some of that care could be an abortion. We have Idaho that has challenged that law. The Supreme Court sent that litigation back to the state court, or to the Ninth Circuit. So we have a bill that is passed that allegedly codifies EMTALA. I don't think it actually does that, but it is consistent with the standard of care, and it says in Washington State, miscarriage management is part of emergency care under EMTALA. So that bill will continue to move. And then one that I forgot to add but is moving is 1392, which is the Medicaid Access Program. So it is a covered lives assessment on the Medicaid MCOs, and that assessment will be used to increase the Medicaid rate paid to providers. So hopefully more providers could then take more Medicaid patients. All right, so I have given you the overview. I was going to say detail, but who knows? The update for right now, what's happening at the federal and state levels. Wanted to give you a couple of practical considerations. As we do these conversations, especially about the federal level, we get people who say, I just feel kind of sad now. You're kind of a black rain cloud. You don't have any good news. You don't have any clear news. And so I will just leave you with acknowledging the uncertainty that we find ourselves in. Hopefully the state uncertainty will get more clear in the next 11 days. Hopefully they won't go into special session. I think the federal uncertainty will continue because I think there's a lot more work that they can and will probably be doing. I find it helpful to think about whether something is a worry, a concern, or a problem. There's a ton to worry about, but you can only spend your emotional worry energy in so many ways. So I try to ask people if it's a worry, concern, or problem. The problems need to be dealt with. Concerns need to be thought about and planned for and addressed. Worries, you might just need to take a deep breath and wait until it becomes something else or goes away. We'll see what happens. I think the other thing to think about is really focusing on the facts. You may get questions from staff, from media, from your community about what are you going to do, what's going to happen. And I think it's really helpful for hospitals and healthcare providers and those of you who are in the industry to really talk in a fact-based way about what do we know now, what are we planning for, what are the contingencies we're considering. And then I think especially if you are dealing with a concern about reducing services or having to make hard choices, being really clear about that with staff, with community leaders, with media, with elected officials. Nobody likes to be surprised. Nobody likes to live in uncertainty. So if you have the power to be clear about what you are seeing and hearing and considering, I would encourage you to do that because we get so much noise in the media, in the social media, in the rumors that we hear that everyone's looking for people who can talk about facts and what it actually means. And then, the other thing to think about is people will fill a void with their own thoughts and opinions or, information that may not be accurate. So if you have the power to be clear and let people know what's happening, I think that will be a real value to you and to your community. The other thing to think about is the timeline of all these things that will or may happen. As I mentioned, sine die is Sunday the 27th, unless they go to special session. And the federal timeline, as I mentioned, a lot of that budget action will probably be in the summer, unless you're doing an Ironman, and then it could be in the fall, so we will see what happens. But I hope that those are at least helpful things to consider as you are thinking about your next steps in this time of uncertainty. I am happy to answer any questions, unless you are fatigued of talking about uncertainty, in which case I can give you back some time. Yeah.
The one thing, you talk about finding the money in revenue, finding the money in cuts, but at least on the federal level and all the headlines that are citing that the high cost of healthcare is driven by the fraud that the hospitals and other entities have overbilled and been unfairly reimbursed for Medicare, Medicaid. And then it always alludes to, we're going to get that money back because we're going to go in and audit them and we're going to put them in jail and fine them. So that's a real popular area that they're budgeting, and nobody talks about that. But what do we see on audit, both on this federal level, and I know that's hard to predict, but also we've had a lot of audits internally from the AG's office about your area, which is the charities laws. So what do you see for that?
Yeah, I think that's a great point. I will say on the charity care, which is in Washington State, there's a requirement that hospitals provide free or reduced health care to people who meet certain income and family size thresholds. And the prior Attorney General, who's now our governor, was very interested in charity care and compliance. I think that Nick Brown, the new AG, will continue to be interested in that area. I haven't heard or seen any audits recently, but I think they are continuing. I think that they're probably kind of the request for information kind of level pieces. For what it's worth on that piece, WSHA does offer to hospitals a charity care checkup where we as experts in the area will come in and look at your charity care program. It's a slight additional fee, but I will say it's me and it's my colleague Kara and our general counsel Taya Briley, and we come in and we do this we don't call it an audit because it's not official, but we can come in and point out if there are any concerns. So if you're a hospital, I really recommend thinking about your charity care program because I do think it's an area of continued potential exposure and one that I think Bob Ferguson put a lot of spotlight on. I think the other piece that we have seen audits and are considering is, as we see HHS, CMS, and others have fewer staff members, do they just have fewer people to do the work? How will that work that they would otherwise do be translating to the audits that the states do as the state steps into the shoes of CMS or other kind of enforcement agencies? The Department of Health is a state agency, and they are subject to cuts. One of the things I didn't talk about is that there have been proposed cuts of 7 to 10% across all state agencies. And so if the Department of Health has fewer resources and hospitals have fewer resources to respond to audits, what will that look like? And I see that I'm over time. Do you want me to stop? Okay. I can pause. I'm an attorney by training, and in court, if you were told to stop, you stop. Otherwise, you get fined, and it's very bad, and it's very embarrassing. So none of that. I think the other question around audits is that, to your point, the perspective of what is right and wrong, and the fact that we would all like to believe that we all agree on what's right and wrong. But I think when we get into things like gender-affirming care, where it's gender-affirming care in healthcare, or child abuse and mutilation, that's a point where I don't know what that will look like, but we have seen and heard more interest in the federal government enforcing that kind of federal perspective against hospitals. I know Seattle Children's has been concerned, and other hospitals across the U.S. So I think that's one that, like, service-specific auditing, I wonder if it's going to happen more.
Do we have time for another question? Okay. First of all, kudos to your charity audit program. Being in an organization that went through it, it was extremely good, very thorough, very detailed, really helps out. Thank you. On page 28, you had a statement on seriously considered but not included to be determined. The 340B, take the discount for the state. I thought that the state already got the discount. I could be wrong, but I was thinking there's no opportunity for the hospitals in 340B for Medicaid patients that I know of.
I think it's a good question. My recollection, and it's been a little while since you saw this proposal, my recollection was to shift some of the way that the funds flow, and I'm now going to get beyond my 340B knowledge because I have not tried to be an expert in 340B because that's a lot of detail, but if you have a question, I think Andrew Boos could probably answer it, the detail. I'm hoping we won't see it, so I'm hoping it will be a non-issue for this session, but I think it could come back in future sessions. Yeah. Okay, well, I'm now very much over time. Thank you so much. Really appreciate you all, and happy to answer any questions afterwards.